So I'm a radiation oncologist at Brigham and Women's Hospital, and I specialize in genitourinary cancers. I've also developed an interest in artificial intelligence and its application for prostate radiation therapy. And so I'm just going to talk a little bit about some of the work that's been done before, as well as some of my work as well for prostate radiation. So here's the outline of my talk. I'm just going to be talking about a simple introduction. Then I'll talk about using artificial intelligence to delineate the tumor on multiparametric MRI. Then we'll talk about using artificial intelligence to delineate the prostate on transrectal ultrasound for brachytherapy, and then some future directions. So artificial intelligence has made many strides in radiation oncology over the past decade. It's really been incorporated into all aspects of radiation therapy, including contouring and treatment. That's the wrong button. in terms of contouring, treatment planning, and even treatment delivery. And I think with each passing year, there's new commercial systems that are out there and that are really integrating artificial intelligence into our workflow and making radiation oncology delivery faster and more efficient. And so this is just one study that talked about using artificial intelligence for contouring edits. And this is on multiparametric MRI. This is simulation scans where people investigated using artificial intelligence and the amount of deviations or contouring edits for the prostate, the rectum, as well as the bladder. And you can see that in many places, there's actually very few displacements of the contours, but in some places, there are more areas where there are more likely to have edits for the prostate, the sigmoid, as well as the bladder, suggesting that artificial intelligence really has promise in terms of helping the radiation oncology workflow for contouring. Artificial intelligence has also been incorporated into treatment planning, and so this was a very interesting study published about 3 years ago, where they used artificial intelligence to generate plans for radiation therapy. This was a study where they used knowledge-based planning to create radiation plans. What they did was that they looked and saw changes in terms of accepted rectal V40, rectum V65, rectum V75, the penile ball, the bladder, at various dose ranges. And they looked at 2 criteria. One was before they implemented knowledge-based planning. And so this is really what most of us do, is we look at a radiation plan, we see that we like it, we approve it, but there's quite a little bit of variability in terms of the plans that are made. And then after this institution instituted knowledge-based planning, all of a sudden, these areas of dosimetric metrics really became much more uniform. And I think that this is potentially one of the benefit of knowledge-based planning is that it can really help make our radiation delivery more consistent between within the institution and between various physicians as well as planners. And then there's also studies that are looking at radiation artificial intelligence for treatment delivery. And so this is actually one of the systems that we have currently at our institution is the Ethos system, where it looks and basically it can follow the treatment plan and take a CT scan every single day, and it can actually deform the images and calculate new radiation plans and allow us to select whether we want to adapt or get a schedule plan, and then we can edit the contours and then choose a plan, and we can have a choice to be able to choose a plan that is a standard plan or a new plan, and then based on this, we can actually deliver the radiation. And what this study here suggests is that using adaptive replanning for radiation therapy can actually improve the delivery of radiation and maximize the number of fractions where patients get all of the dose to the prostate. And the reason for that is because, each day we have patients that come with various, bladder filling and rectum filling and prostate movements. And, we always assume that the treatment is the same every single day, whereas in fact, the prostate will actually move through fractions just based on the patients, the different amount of bladder filling. And what this study suggests is that actually following the patient and replanning every day, you get better treatment regimens. And the reason that we're able to do this online adaptation is because we're actually following the patient every day and using artificial intelligence to generate new treatment plans every day. And we can actually do this with our system over the course of 20 minutes. And so this is just kind of a flavor in terms of the radiation oncology workflow and how artificial intelligence can really help us better define and make our treatments safer for our patients. And so, I just want to talk about a couple of projects that I've been focusing on over the past several months, and just to talk a little bit about how artificial intelligence can be helpful. And so, many of us in prostate radiation therapy, we've heard about the FLAME trial. And what the FLAME trial, what it was a trial that compared patients who had standard radiation therapy or dose escalation to a tumor that's been seen on MRI. And this study was published a couple of years ago, but it really made waves because what it showed was that if you give patients a standard dose of radiation to the prostate, but escalate dose to the tumor, you can actually have an improvement in terms of biochemical control. And so this was the main graph where you can see that patients who had standard radiation therapy, there were more biochemical failures than patients who had boosted radiation therapy or a focal boost. And so in this trial, the standard regimen, everyone got 77 gray in 35 fractions. And then in arm 2, patients had a dose, a boost to the dominant intraprostatic lesion up to 95 gray in 35 fractions. And the study showed that the biochemical disease-free survival, the hazard ratio was 0.45. And so what this suggests is that giving patients even just a little bit of more dose to the tumor, you can really improve patients' outcomes. And you can do it in a way that doesn't really compromise GI or GU toxicities. Now, there are a greater percentage of patients who had late GU or GI toxicities with the focal dose escalation, but it didn't lead to a lot of the greater percentages noted for patients who had received, let's say, brachytherapy boost on Ascend-RT or other studies. And so this is currently what we have implemented, or we're learning to implement in our clinic as well for patients who don't want to get brachytherapy boost. I think one of the challenges, though, is actually trying to delineate where the tumor is on multiparametric MRI. So as you all know, the tumors on multiparametric MRI, you see the T2 and the ADC, and you see the perfusion images, but it often can be very difficult. And it can lead to a lot of variability in terms of how do we, in terms of where the tumor actually is on the MRI. And so this was an interesting study. It was also done by the FLAME group. And they looked at 3 different institutions. And it looked at how their contours were different between the institutions based on the T2, the ADC, and the perfusion imaging. And what they found was that, many institutions contoured tumors very differently. And I think that what it really suggests is that there are some cases where it's very difficult to, people may contour very differently, and it may have possible, dosimetric consequences. And it's not a very, it's not a very trivial problem. Let's just put it that way. And so this is one study, this is one patient who had a tumor on the MRI, and this is an endorectal coil MRI. And the tumor is in the prostate apex. It's on the left apex of the prostate. It's near the urethra. Here's the rectum. And we had 5 radiation oncologists actually contour the tumor, and they contoured it independently. And in this particular case, there was actually pretty good agreement in terms of how the contours all overlap with each other. And so most likely there wouldn't be much difference in terms of dose to the tumor, and there would be pretty good consistency. I think the issue is that not all tumors are like this. And so if you see the image right here, you can see that there are many different contours. All the contours look incredibly different. So in the red, you see that someone just really highlighted the darkest area of the tumor, whereas the person in the purple really just wanted to really cover more broadly or more diffusely. And all the other contours, there was something in between. And which one is actually the right answer? The question is we don't know. What we do know is that on ADC map, it looks like the intensity of how the tumors, how intense the tumors are, or the density of the tumor. So we know that the tumors in red are the most dense, but do we boost the whole, just the tumors in red, or do we kind of boost the larger areas? And we don't really know the answer to that question. And so in this study, what we wanted to do was to evaluate whether artificial intelligence delineated contours can provide a similar degree of dose escalation as radiation oncologists delineated contours. In other words, we wanted to see, can we have an AI algorithm tell us where the tumor is so we don't have issues where you get so much variability? And that's really what we tested in this. And so we obtained patients that were treated with external beam and had a multiparametric MRI back between 2010 and 2013. And we wanted to compare the artificial intelligence versus the radiation oncologist tumors with respect to detectability, geometric accuracy, and the amount of dose escalation to the tumor. And so, we did this similar thing when we look at artificial intelligence. We have a training set, and we have a data set, a testing set. And for the training set, we had images of patients who had, multiparametric MRI, so T2, ADC, and diffusion-weighted images. And we labeled them peripheral zone, the transitional zone, the dominant intraprostatic lesion. And we basically gave the artificial intelligence algorithm the answer key, or what we think is the answer key. And then we trained this with an algorithm. This is called the UNet. UNet is a newer algorithm that was developed in the past 5 or 10 years that can really revolutionize the ability to segment things consistently without using various features. It just takes the images and it just gives you the result. So that's really why I like it. And then we also had 10 sets, a testing set. In the testing set, there were 35 patients with PIRADS 4 to 5 lesions. We had 5 radiation oncologist contours, and we had an artificial intelligence contour that came from the UNet. So in this particular case, the UNet says that the tumor is here, and the peripheral zone is here, and the transitional zone is here. So it looks like it's pretty good. The tumor, the algorithm can really tell us, give us a good result in terms of where things are located. And there's been many studies that have showed that it's been very useful. And so, we can kind of compare how well does this artificial intelligence locate the tumor. So in this particular case, this was the reference contour, and this was contour with the input of a radiologist. These were the observers. The red is the artificial intelligence. And so in this particular case, all the observers contoured things appropriately. The AI algorithm contoured things pretty appropriately. It was, and so in this particular case, there was really good agreement between the artificial intelligence and the 5 radiation oncologist observers. In this particular case, it was also good. It was detected by everybody. But there was some difference, and this was the same image that I showed you before, where there's a lot of variability. Artificial intelligence is right here in red, but there's a lot of kind of inconsistencies between the various observers. There's also cases where the artificial intelligence detected a lesion that was actually not detected by the radiologist. And we call these false positives because the radiologist didn't detect it, but the artificial intelligence detected it. And in this particular case, the artificial intelligence detected it, but so did one observer. And it showed that this was kind of a diffusion-restricted area in the right anterior prostate. And I mean, there might actually be cancer there. We don't really know. But it was just something that was noted. And then this is a false negative, and this kind of shows you what are the potential limitations of artificial intelligence. In this particular case, there was a tumor that was identified as a reference tumor, but artificial intelligence, it didn't really show it anywhere. It didn't actually detect it. And maybe it's because the image was a little bit more hypo-intense, and so it didn't really show where it was. But it was kind of a false negative. And so what we did was we wanted to see, well, how did the artificial intelligence compare with the 5 radiation oncologists? And what they showed was that there was actually more false positives for the artificial intelligence. And so there were 11% false positives, whereas it was very few for the other radiation oncologists. That also showed that there were some, maybe possibly more false negatives. And so artificial intelligence didn't really detect everything that the radiation oncologists detected. And, and the radiation oncologists, they also all had PIRAD scores. And this kind of was reflected in the sensitivity. It's a little bit lower. The positive predictive value is definitely lower. And so this kind of just shows that this is some of the limitations of artificial intelligence for detecting individual lesions. Then you can see, well, how do these things compare in terms of geometric accuracy? And so what we can see on this slide is that, the tumor volume that's delineated by the artificial intelligence algorithm, it's in general smaller than those from, 4 of the 5 radiation oncologists. But in terms of the volumetric agreement, or what we call the Dice coefficient, it wasn't really different. And so it actually gave pretty good contours for the lesions that were appropriately detected. And then we can see, well, what are the dosimetric consequences of this variability? And so we actually used one of the treatment planning engines from one of the, that's kind of used kind of in a research mode. But these are the MRI scans that you've seen previously, and then these are the images of the radiation plans. And so you can see the very dark is 123% dose escalation, the 100% is in the orange, 50% is in the green. So in this particular case, the AI plan had a dose escalation that looked pretty similar to the first radiation oncologist, so we actually really liked this one. We can say, well, for this particular case, using the AI contours gave a really good plan. How about this one? In this case, you can see that the area of dose escalation was pretty high for the AI plan to a very small region, whereas it was pretty high to a much larger lesion for R01. And so there was kind of different. And the reason for that is that the DIL volume is different. And the other thing is that, it was much harder to, we still try to meet the rectum and the bladder metrics. In this particular case, there was a tumor that had a false positive that was boosted in the AI algorithm. And so you can see that this kind of boosted something that, we're not sure if it is a tumor or not, whereas the RO plan, there was no difference. And then in this particular case, this was the case where there was a true positive lesion that wasn't boosted. The AI plan, there was no boost, whereas the RO1 plan, there was a boost. And so you can see how, differences in contouring can kind of lead to differences in, functional outcomes or dosimetric consequences. And, so when we look at our dosimetric comparisons, and this is to, the dose to the, to a kind of the answer, the reference dominant intraprostatic lesion, the AI algorithm actually gave a pretty good dose. And so it was actually greater it was actually no different for 2 out of the 5 radiation oncologists, and a little bit greater than 3 of the 5 radiation oncologists. So it gave a plan that was actually pretty good. And you know, these differences in terms of the dose to the actual lesion that's outlined by the observer, we didn't really see many differences after accounting for dull volume, bladder proximity, or rectum proximity. And so what it just shows is that, you know, the volume of the tumor that's outlined and its distance to the bladder and rectum can be associated with the dose that you can achieve to the dominant intraprostatic lesion. And then this is just looking at the reference GTV. You know, you pretty much get similar doses with the AI algorithm. And so I think what we can conclude is that, you know, the AI provided a GTV reference dose that was similar to 3 of the 5 radiation oncologists, and that AI delineated DILs could be utilized for, you know, actually DIL boosting. And so we could use this to help us outline the tumor and give a much higher dose to the tumor. What we also found is that we also need to have prospective evaluation because there were some false negatives, there were some false positives, you know, and then we also need to be cognizant that this may not be appropriate for all patients. Some patients may have, you know, adverse toxicity profiles, and some patients with very large lesions may be able to get greater dose escalation with brachytherapy boost techniques. And so what this really says is that prospective trials are needed for AI DIL boosting. So we just want to see if there's any questions or concerns for this. Okay. And then I think the second one I wanted to talk about is using, you know, delineating the prostate on ultrasound. And so this really talks about, you know, what a case of treating with high-dose rate brachytherapy. And so with high-dose rate brachytherapy, what it involves is it's inserting catheters into the prostate and treating with the radium-192 source. It's a little different from low-dose rate brachytherapy because we don't really insert radioactive seeds into the prostate. But it's you know, nothing radioactive is left in the prostate. It provides excellent biochemical control compared with external beam radiation, and it has a better quality of life than low-dose rate brachytherapy. And so, you know, we do most of my practices with the brachytherapy techniques. And I just want to review really quickly what are the workflow for brachytherapy. And so one is, you know, you put the patients in stirrups, you insert the probe into the rectum, you visualize the prostate, you then insert needles into the prostate, and then you outline the prostate, the rectum, the urethra, you create a radiation treatment plan, and then you deliver the radiation. And so all the radioactive sources will go in and, you know, treat the prostate, and then all the sources will go back in the machine, then you pull everything out, and so the patient is no longer radioactive. So, you know, one of the big challenges in terms of, you know, high-dose rate brachytherapy is actually outlining where the prostate is. And it's not very easy. And the reason for that is that you have a lot of catheters that are here. The catheters cause a lot of streaking artifacts. You have blood, you have calcifications. Some patients have prior brachytherapy seeds for patients who failed treatment. There's poor soft tissue contrast. And so it can be very difficult to be able to tell, well, where is actually the prostate? You know, and it's not really a trivial task, and our residents really have, you know, some difficulty in terms of identifying where the prostate is. Once we contour the prostate, right here, the urethra and the rectum, we do radiation treatment planning, and so our physicists basically create a radiation plan based on where the needles are, and then we deliver the treatment, you know, with basically this is an afterloader that has a long needle, and the radioactive source goes through here and delivers the radiation therapy. And so in this particular case, we wanted to see, well, can we use a UNET, which is similar to what we used in the prior study, to be able to tell us where the prostate is, you know, with the artificial intelligence, and not really have, you know, and then compare it to our gold standard or the reference clinical contours that we used. So once again, we had a training set with 110 patients, we did a validation set with 20 patients, and a testing set with 20. And really, all of this, the study really focuses on this testing set. And so here are some examples of 3 patients. This is patient number 1, this is patient number 2, and this is patient number 3. You have the reference contours, so these are the contours that we use for treatment planning and delivery, and so they're in red. You can see that for this particular case, the reference and the AI contours look really good. And so it suggests us that the AI algorithm can really give us a good representation of where the prostate is for this particular case. In this particular case, there was some variation. In here, the reference contour was in red. It's a little bit angulated, kind of chopped off up here. There's kind of some interpolation artifacts. AI looks pretty consistent all around. So this one, the AI contour actually looks pretty good. And possibly even better than the one that was used for treatment planning. But how about this one? So this patient had a prostate, they had the urethra, the rectum was down here, but there's also a rectal spacer. And so in this particular patient, this patient had external beam and a rectal spacer was placed to minimize dose to the rectum. And then they had brachytherapy with me. And in this particular case, the AI contours kind of went into the rectal spacer. And so if you look at this here, you can see this doesn't look like the shape of the prostate. And in this particular case, actually the reference contours look better than the AI contours. So what we did was we wanted to look, well, the AI algorithm was able to find the prostate in all 20 cases, so we were happy with that. And then we wanted to see, well, how accurate is it? How much does the geometry match? And so in this particular case, we see, well, this is for the whole prostate, that there's actually a good geometric accuracy, for these 20 cases between the AI and the reference contours. So we're pretty happy to see that. It seems like, the accuracy may be best in the mid-gland, a little bit worse for the apex, maybe a little bit worse for the base. But the accuracy is pretty good. And then what we did was we had, 8 observers come in, and they wanted to tell us which contours they preferred. And so it's like, did you like the red contour, or did you like the blue contour? And we didn't really tell them which one was from the AI algorithm or which one was from the clinical algorithm. And then we also asked the observers, well, tell us what you think about the contour in blue. We didn't tell them it was an AI contour, but would you make no edits, minimal edits, moderate edits, or major edits? And so this was done for all 20 cases, with 8 different observers. And it was very interesting to see, what the users thought. So in this particular case, where there was almost complete agreement between the AI and the reference contours, pretty much it was half and half. People couldn't tell the difference, so half preferred the reference and half preferred the AI. Whereas in this one, pretty much everyone preferred the AI. Probably because they didn't like how this kind of went, it was actually more of an interpolation artifact that went into the base of the prostate and the seminal vesicles. So this one, they really preferred the AI. And then how about this one? This one, everyone preferred the reference contours, but because they saw that in this particular case, the AI contours really went into that rectal spacer. And so in this study, what we saw was that the observers preferred the AI contours for actually the majority of the cases. And it's actually, I always thought it was surprising, but if this keeps on getting better and better, maybe they can replace us with a computer. and the percentage of cases with no or minimal edits, the median value was 72%. And so you can really see how for many of the cases, you could just have the computer algorithm segment it for you, and you really wouldn't need to make any edits to it. And we also did a study where we had residents that came in, 5 residents, and they had to contour the prostate on the images independently by themselves, so without any, without any assistance. And if we just look at this, this is just one of the values, the Dice coefficient, which looks at kind of how much the overlap is. You see it's actually pretty variable, and I'm just focusing on these in red. What you can see is that, observer 2 actually, had a lower performance than some of the other observers. Observer 1 actually did really good, and observer 4 was somewhere in the middle. And then what we did was we asked the residents about 2 or 3 months later to recontour the prostate, but give them the AI contours to edit. And what we actually found was that when the observers just edited the contours provided by the AI algorithm, they did exceptionally well. And in actuality, the observers made very minimal edits to the AI contours. And so what we see here is that the presence of AI improved the Dice coefficient by about 0.11. It's, this is a very interesting study because what it can show is that AI algorithms could help improve, geometric accuracy for, resident radiation oncologists or even earlier career radiation oncologists as they progress through the treatment. And I think it's probably generalizable to other systems. In summary, AI delineated prostate contours for brachytherapy had high geometric accuracy. The geometric accuracy was better at the midgland than the base and the apex. The observers preferred AI contours for the majority of cases. But for cases with the rectal spacer where there wasn't a lot of cases in the training data set, it didn't really perform as well. AI contours improve the geometric accuracy of resident contours, and prospective data are needed to better learn how to incorporate AI prostate delineations into the HDR brachytherapy workflow. This is AI algorithms. It's definitely coming. I feel like the field of radiation oncology will be markedly different in 5 or 10 years, where maybe it might become like medical oncology, where we want a radiation plan and we prescribe the radiation, and a computer does the contouring work, the treatment planning work, and the treatment delivery work. And the physicians can focus more on the clinical aspects rather than the treatment planning aspects throughout the care. AI algorithms could significantly reduce physician and dosimetrist workload in contouring, treatment planning, and treatment evaluation. A lot of work is needed to better understand the limitations of AI in order to maintain patient safety, and so AI doesn't work in 100% of the cases, and so, for the first study, it may miss lesions, and in this brachytherapy contouring, it contoured into the rectal spacer, and treating based just solely on AI without reviewing things may impact patient safety, and so we need to figure out, can we detect those cases? How do we get the user to come in and help us better adjust, to intervene so that we can actually make sure the treatments are safe. And we really need prospective data to better understand how to incorporate AI into the physician and the physicist and the dosimetrist workflow. And so just want to thank everybody that was involved in these projects, and just want to see if there were any questions from the group. Yeah.
Very appreciate your very enlightening lectures. Actually, I have a question about the content in the slides. It was mentioned that artificial intelligence contouring has some limitations in that it shows higher rates of false positives and false negative compared to radiation oncologists. And my question is that since the AI system was established using data from radiation oncologists, it naturally includes intrinsic inter-observer and intra-observer variations. So it's not surprising that AI only captured those inherent variations and biases. So considering these limitations, what suggestion you may give for dealing with that kind of challenges in future research efforts?
Yeah.
Thank you.
Yeah, that's a very good question. The question was that the AI algorithms had, at least in the first study, kind of decreased sensitivity as well as decreased positive predictive value, and this is something that people have seen in very large data sets too, and so cases where there's thousands of tested patients in the testing data set. They also see that the AI algorithm misses more lesions than radiologists for detecting PIRATS 4 or 5 lesions. I think it's challenging. I think that in terms of identifying the dominant lesion for prostate MRI, I don't think that we're at the point where we can say that we don't, that we can say we can use it without any radiologist input. I think that there are newer algorithms out there where they can do false positive suppression techniques, and where it can try to gather more information from the data. But I think that the other limitation is that there's so much variability in terms of how the lesion delineation itself or the lesion identification itself. And so I think that what the AI does is that it really does things consistently. Now, it can do things consistently wrong or do things consistently right, but it can take an image and it can just repeat it, And so the real key is to actually figure out, can we get larger data sets? Can we develop new algorithms? And at least for that particular problem, there's this large challenge where people are trying to get the best algorithm that performs the best. And so there's a lot of work that's going into it, and we'll be interested to see the results of that. Yeah.
Thank you.
Thank you. Any other questions? Yeah.
Thanks for your nice talk. I have two questions, and the first one is possibly quite similar to the question just asked, but I would like to ask in an aspect of study design, which is that in the beginning, you mentioned that there are some inconsistency between radiation oncologists on contouring the prostate tumor from the MRI image. So when you doing the model training, when you collect the data set, when it comes to the images that showing maybe lower consistency between radiation oncologists, how do you decide the ground truth, meaning the label of those images, or you just exclude such data for to get a better performance on training those models? This is the first question.
Yeah. So what we did was that the ground truth was really what I contoured before I gave it to the other radiation oncologists. And we had a radiologist that could review the contours and make sure that they looked appropriate. But we didn't have multiple people that could really establish a ground truth. And it's one of the difficult things is that since we don't have a prostatectomy specimen before us, it's hard to know exactly what the real ground truth is. But that's how we did it in the study.
Okay, thank you. And the second question is that I know that in semantic segmentation in such models, they can offer some information for us that maybe it's not like classification model that some people saying that those deep learning models are like black boxes, and we can get some information from those semantic segmentation models. But I'm curious that do you have any further analysis doing after the model inference those result, and you can try? Do you have any method try to analysis those results that for some clinical aspect that for example for example in radiomic points of view or other
Yeah, I think that's one of the biggest criticisms of AI is that you don't really have a biological model to really show what things are being done. I think that in terms of the best kind of functional outcome was the slide that was looking at the dosimetry. And these were basically what we did was we had, we basically looked at the dosimetric outcomes of contours from the 5 different observers, compared with the AI algorithm. And we can see is that, and this is the dose that will reference tumor that what I did was our gold standard. And what we could say is that the AI algorithm, there's actually quite a bit of variability in terms of the doses, and this is over 35 patients to where the tumor is. But things kind of perform pretty much similarly. And so we have some functional outcome in terms of how high the dose can be, and this was using the flame metrics. But I think that looking at very patient-specific, it can be challenging to really see what are the functional outcomes. And I think some of this you can just see here is that this variability in dosing can lead to this one gives a much higher dose to a much larger volume than the AI plan, for example. And so this can kind of give us some information on the consequences of the variability, but I think there's still a lot more work that needs to be done in terms of really understanding like what it's being done, because it is still a black box and you really can't deconstruct it in a manner that is kind of interpretable. Yeah.
Thank you.
Thank you. Yeah.
Thanks, Martin, for those great talks. I have one question about, you mentioned in your last slide for the, we still need a prospective trial evaluating the AI integrating for the clinical workflows. And so what's your opinions on what are the appropriate metrics or parameters, whether these AI is improve the workflows? Thank you.
I think that a lot of these trials, so like over the past 5 years, people have looking at the performance, but now the question is how do you get it into the clinics? That's a great question. We don't really know exactly what the optimal trial design is, but I think what it could be is that it can, you can look in terms of how much does your treatment plan ultimately deviate from the AI? And so you can say, well, did I use the AI contours for 80% or 90% of the cases, or just 30 or 40% of the cases? You can look at the geometric accuracy. You can look at, but I think that the key is to really get the radiation oncologists and radiology input, independent inputs, to really see whether the AI is giving us something that we actually really want or don't want. What we don't want to see is that people just accepted the AI output and you get tired at the end of the day, like this looks pretty good, I'm just going to use it, and then you find out that there's an error that's in there. And so I think that that's a great question, and we're trying to figure out how do we design the trial that we can maximize the output and make sure that it's safe. But I think that that's very important, but having independent oversight I think is going to be critical.
Thank you.
All right, thank you, everybody.